is a CT, and then we have a follow-up
Steve, you just
MRI.
missed a mesenteric lymphangioma, just like your case. Not responding.
So this is a non-con CT, and patient is end-stage kidney disease, has a renal transplant, and I want you to focus on the renal lesion. This is important because we see this commonly, right? Non-con, and you have a renal lesion. What are you going to do? So what do you guys think?
We just had some.
Something solid in the superior polar right kidney.
Good.
Potentially solid.
Potentially solid, right? Good, exactly. So we can do some ROIs. Here is 41. Here is, 41. Here is, so it's solid. And so, I mean, we classically say 20 ounces per unit as the cutoff for lesions, right? But I think the newer approach now is to look at the heterogeneity as well. So if it's heterogeneous, because you can have areas that are cystic and others that are solid. So we should, at least based on the SAR presentation from Matt Davenport, who chairs the RCC DFB committee, we want to look at the heterogeneity on the non-con, because even if it measures less than 20, it can still be a mass. So we have MR.
The other tip for residents is if it's above 70 on the non-con, then you can be more confident that and it's homogeneous, so you can be more confident that it's just a hemorrhagic cyst.
So here it is on the FAST T2. I'm going to point that out to you, and then I'll give you the, so actually I think on the coronal is maybe better. Here's the contrast enhanced portion. It's right there. And then let me look. Here's the coronal T2. So it's T2 dark, and then there's no enhancement. Any thoughts? And there's no signal dropout on in or post-phase imaging. So this is the post-phase imaging, and there's your lesion. And then here's the in-phase. There's no dropout. Oh, that's the post-phase again, sorry. And in the contrast enhanced, there's no, it's T2, it's T1 dark and T2 dark. Any thoughts? And I'm going to pull up the contrast here.
Hemorrhagic cyst.
Hemorrhagic cyst, that's a great thought. What do we typically see on hemorrhagic cyst on the pre-con?
Usually you see T1 brightness.
Good. And so here's the T1. So if it's a hemorrhagic cyst, it's usually bright, or proteinaceous cyst is like intrinsically T1 bright, but this one is like dark all around. So I don't know what the answer is, but it's benign, whatever it is. I thought it was like a fibrous lesion because the T2 is so dark, and you just don't expect it to be that dark, you know?
I think it depends on the state of the blood. Like if it's dark, really dark on both, it's different blood. I would have actually thought maybe even was like potentially calcified or has a lot of iron in it. The CT showed it wasn't really calcified, but you could, I don't know, did it bloom on the in phase?
I don't know. I don't remember. It didn't have calcifications on the CT.
Right, but it could still have iron.
Oh, I see. Oh, that's a good point. I didn't think about that. Where is it? Oh my gosh. Where is the in phase? Here?
Everyone's watching, Nelly.
I know. This is so much better than like my other setup though. There it is.
Right, but show the out of phase.
Out of phase is, it doesn't bloom. I think it stays the same. Dark and dark.
No, it just bloomed. Look how much darker it was on the in phase.
Yeah, especially.
Let's find out. Let me see. Here, let's do it side by side. Maybe that. I don't know how to make this bigger. Sorry.
It's fine. Okay. Just yeah. Look, it's blooming.
Oh, so it's like an iron. So it's getting brighter. That's what. Is that what you're referring to? What you mean by blooming?
It's getting darker on the in phase. Do you see how it's getting darker on the in phase?
Yeah. So it's dark, and then on the out of phase, it gets brighter or increases signal.
Right. I would say it the opposite way. I would say it's getting darker on the in phase, which is blooming, and that's because usually on a 1.5T, the in phase is the later echo. Mm-hmm. So anything that creates susceptibility, such as iron, air, and metal, will get darker and bloom, or get darker and usually bigger on the in phase. That's called blooming.
Ah, I see.
This suggests to me that there's a lot of iron in this, which is just a different level of blood.
So it's like a super old hemorrhagic cyst.
Yeah.
Cool. That's awesome. So it's Bosniak too, either way. So the patient doesn't need follow-up. And I brought this case up because of the new guidelines. Well, it's not really guidelines. It's more like standardized reporting. So the SAR now endorses a standardized reporting templates for indeterminate renal masses that was just recently published this month. It was presented at SAR plenary session, but there are core items that we should include in our template reporting. I'm going to update our templates to include some of the things that our current template doesn't currently have. But we should obviously talk about the mass, the growth rate, the type of mass, cystic, solid, indeterminate, classified if you can with Bosniak. So this is going to be a Bosniak 2. You want to describe presence of macroscopic fat because that tells you it's an AML. Unless it's a lipid poor AML, then you won't have macro fat. And then enhancement. And then information that's important to the urologist. So this wasn't on the prior templates, specifically the capsular location, if it's exophytic, endophytic. And the reason is because it changes their surgical approach. And probably also prognosis. Exophytic lesions are very easy to resect, whereas endophytic lesions are very difficult and can bleed a lot. And of course, tumor thrombus extension into the IVC, renal vein, because that also impacts their surgical approach. And they might get vascular involved too if it goes into the IVC. Yeah, I'm going to update our template, but there's, these are the specific items that we should be talking about for future.
It's interesting that they want us to report all of this, even if it's an indeterminate mass.
Yeah. Yeah.
So every renal lesion, guys, get your template out.
Yeah, right. And what are these pointing out is like some masses are clearly RCC, right? They're malignant, and so this is specifically for the ones we're not sure about. These are the features that we should be reporting. So it's specifically this area of that we're not really quite clear clinically about, like what to do with indeterminate renal masses, and this is what they want us to report.